Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we have a very interesting topic that I think you will enjoy because we're going to be talking about terms that we throw around all the time. Healthy, normal, average, and we're really going to take a deep dive into what those terms really mean and why you should be interested in them, because so many of these words help to push the kind of care and treatment that you're getting, and we're going to stand back and really take a look at whether or not that really fits your situation. So the name of our show, the title of our show is Know Thyself, the difference between health, wellness, and being average. Now, I think you're going to enjoy this because we have a returning guest who is an international and world-renowned ophthalmologist, and he is going to be talking from his experience of more than 50 years as a practicing physician, but someone who really did have to also stand back as a physician and take stock and think about how his care and treatment was going and how he had to really learn from his own practice working with people. So I'd like to introduce our renowned guest, Dr. George Spaeth. He is working at the Wills Eye Hospital in Philadelphia. He is a researcher. He is a who's who in his field. Anyone who is an ophthalmologist knows Dr. George Spaeth and the work that he has done. So I want to thank you, Dr. Spaeth, for being with us. It's really a pleasure. In our first show with Dr. Spaeth, he is an expert in glaucoma, and he walked us through glaucoma detection, treatment, how it basically works. I would say it was glaucoma 101 in depth. But I think that in this show, he's not going to talk about just glaucoma. He's going to talk more broadly about these concepts. And what we want you to do is to think about how it applies to you. And our key points, which we are going to be outlining as we go along in this discussion, are really that at the end of the day, you as the consumer are really going to have to take responsibility for your own health and wellness. So you understanding some of these concepts is going to be very, very pivotal in that relationship that you have with your doctor or your treatment team, so that that relationship may require ongoing monitoring rather than just a one and done diagnosis. The other thing we're going to talk about is how you assess your own health and wellness, how you are tuned in to your body, and how part of that plays a very significant role in how the treatment plan is designed and how your outcomes will really evolve over time. So again, I think, George, if you could get us going on this, I think a place to start is your own lived experience as a physician, because this is something that, again, evolved for you. It wasn't something that you thought of when you first got out of school, for instance.
Absolutely not. No, this was very definitely, it was a painful evolution.
Well, tell us about that.
Glaucoma, like lots of things, has definitions, and when I was learning what glaucoma was, we knew what it was. It was pretty simple. You measured the pressure in the eye. Many years ago you did it with a finger, now you did it with an instrument, and you got an idea of what the pressure in the eye was. And we knew that you studied 10,000 people, and the average pressure of those 10,000 people is going to be 15. And then it's going to be some people have 16, fewer will have 17, very few have pressures more than 21 or so, less than 5%. So most people are around 15. So glaucoma was pressures over what most people have, was over pressure of, let's say, 21, or some people said 24, something like that. So you came to see me, and I measured your pressure, and I said, how are you doing? And you said, oh, I'm doing fine. I said, well, no, you're not. You know, your pressure's 27, and you've got glaucoma.
So in those days, just that reading alone.
Well, that was it.
Right.
That was the definite. You have glaucoma. Your pressure's 27. You're way out there, and they say, well, what's that mean? Well, it means you're going to go blind. So, needless to say, I wanted to treat you, and you wanted to be treated. So I would give you a drop that makes your pupil small, that makes the fluid run out of the eye, and that brings your pressure down often, but it also blurs your vision. And if you were nearsighted, sometimes it pulls on the muscle so hard that it causes you retinal detachment. So you do go blind, but not from glaucoma.
Right. So it had really some very serious consequences.
Very serious. Another drug that we used was one which isn't used very much anymore. It's called Diamox, and it lowers pressure also. And it lowered pressure very well, but it's a potent drug. It upset people's stomach, gave them rashes, and sometimes it killed them. Well, that was the cost, risk-benefit ratio. You've got pressure over whatever. You've got glaucoma, you're going to go blind, so you need some risk. That was pretty straightforward. Now, while I was taking my training, there was a doctor at University of Iowa. His name was Mansur Armale, and he said, I think that's too simple. There seem to be some people whose pressures are pretty high who don't ever go blind. So he and a group of others set up a study to study people with pressures that are above normal, above average.
So let me just stop you right there. So he did not come forward with this idea with the bias that just because you had a certain number, you immediately had glaucoma.
That's right. He said, let's test that. Well, I can remember reading about this, didn't hear about it. I was furious. I thought, that's unethical.
In what way?
Well, my gosh, everybody knows if your pressure is such and such, you're going to lose your sight.
Right, because you learned it in school.
That's right. And furthermore, there seemed to be very good evidence that was the case.
Mm-hmm.
But he was going to do something that was really out of the box. Well, he did it. And he did very carefully and very responsibly. And what he found was at the end of 5 years following people whose pressures were not average, that were abnormal, only 5% of the people developed any damage.
That's pretty remarkable. 5%.
5%
is very low. So
it is pretty low.
So out of 100 people that were immediately diagnosed as having glaucoma, only 5 people out of that 100 actually became blind.
That's right. Or not became blind, started on the way to becoming blind.
Oh, so they weren't even fully blind.
Oh, no.
Right.
They just had some minor change. So all of a sudden I thought, 95% of the people I've been giving red eyes and blurred vision and killing some of them, they didn't even need treatment. Well, it was pretty scary.
That is, but how did the medical community respond? You're saying how you responded, you were astounded. How did other people respond? It's
slow to, it's hard to get rid of something. Nancy, the Hindu Trinity is very interesting. I'm not losing it, okay? The Hindu Trinity is very interesting. There's Brahma, the creator. You have to create things. There's Vishnu, the maintainer, keeps things in shape. And then there's Shiva, the destroyer. And I remember when I first heard about the Hindu Trinity, I said, why would you want a destroyer? Because giving up something that you think you believe, that you really know, that's really godlike. So it's not easy to do.
So it's destroying in a good sense of the word.
It's destroying in the sense you've got to get rid of things that are wrong, things that are obsolete. I don't know about your house, but I got a lot of stuff I got to throw away, and that's tough. And throwing away ideas that we believe, that's toughest of all.
Right. I think that's a great story, though, because after all, you went to an outstanding medical school, Harvard Medical School, So this was the doctrine of the day.
It was the doctrine of the day,
Right.
And it was the other side too that we need to think about also. So here now you come to see me, and you tell me, I don't think I'm seeing quite so well, and I measure your pressure because maybe you think you have glaucoma in the family or something like that, and I find that your pressure is absolutely average, 15. I say, oh, well, you don't have glaucoma. But then a doctor in Wales, Peter Graham, and an epidemiologist in Wales, Cardiff, Fred Hollows, said, you know, maybe the other side of this needs to be looked at too. And they did that. They went to a little town in Wales, Ferndale, and they examined all the people over 40 in Ferndale. And they looked inside their eye to see if they had optic nerve damage like glaucoma causes. They measured the way that people see to see if they had field loss, the way glaucoma causes field loss, and they measured their pressures. And what they found was that 1/3 of those who had glaucoma damage had normal pressures, had average pressures. Let's not say normal, because normal is confusing, but they had average pressures. So, just average doesn't mean you're healthy, and not average doesn't mean you're sick. It's the degree away from that average that really counts. Now, if your pressure is 50 or 60 or 80, yes, you're going to have some problems. But in that range, it's within, I shouldn't use the word standard deviation. That might be confusing to people, but it's going to vary with the finding. Some people have pressures that are high and some never get worse, and some people have pressures that are low and go blind.
Right. So how did that work? I mean, obviously there was this standard that was set, and again, this is in our discussion around glaucoma, but there's standards for many other tests for many other diseases that had to be set at that range for some reason previously.
Mm-hmm.
But and it worked for certain people. But what you're saying is that in some cases people were overtreated. The first 100 people that were in that range that was considered too high, they were getting too much treatment because only 5 out of that 100 really needed some treatment. What you're saying is in the lower range of that scale, people that actually had some very serious diseases, they were not treated at all because they were considered normal. They
That's
were
right.
in the normal range. So these are two bad outcomes. Either overtreatment is a bad outcome, or undertreatment and completely missing it is a bad outcome. So why did that range of numbers get established in the first place?
Years ago, before science really came into its strength, people didn't think so much in terms of numbers or in terms of statistics and things like that. They thought in terms of qualities, in terms of how they felt. And a disease, interestingly in English, a disease is something that makes you not feel comfortable, a disease. But those qualities are hard to measure, and when science really came into its own in the 1800s, largely really, all of a sudden, wonderful things happened. Because you start to measure and you could determine cause and effect much more accurately. It was a huge step ahead. But it didn't have only good things to offer. Because it tended to concentrate only on the standard, on the average, and if you weren't standard, you were called an outlier. And it was assumed if you're an outlier, you're sick or something like that. And you don't really know how to handle that statistically, those outliers. And it's taken really years for us to start to realize the limitations of the way we've been thinking about the standard distribution curve and what's average and what's normal and what's an outlier. And as we're learning more about that, we're learning that the genetic differences in people are huge. And of course people have always known that. Jack Sprat could eat no fat. His wife could eat no lean. You know? We've always known that there are these differences.
Right.
But now we know that they're not so easy to define away just in terms of statistics.
Right. So I think that what I hear you saying to us is that before science really became a dominant player in the whole determination of health and illness, people were able to discuss their feelings of illness much more clearly, or they were able to have a discussion of what they felt was normal for them or abnormal. Science came in and started to really determine more of this, so that it was an asset in some cases, but in some cases it could actually be a liability.
Yes, I think it's very important to learn to listen to your body and to learn to take care of yourself. And if you're feeling energetic and well and everything feels great, the likelihood is you're probably in pretty good shape. Now maybe some illness is developing that you don't know about, and that can certainly happen with glaucoma, for example. But you can't, as a doctor, you can't make an asymptomatic patient better.
That means somebody that doesn't have any symptoms.
That's right. Thank you for clarifying. A person who feels fine feels fine. The other side of that is when you don't feel fine, don't let people disregard it. Most of all, don't disregard it yourself.
Right. I think that is a really important point. So let's like stick with our glaucoma example. That would be a little bit of a tough one, because if you came in with a normal number, so to speak, by the pressure reading of the eye, you told us in our previous show that glaucoma is really a stealth kind of illness. People don't feel necessarily pain and suffering until it's way too late for any time that they even have that. So how would we find other ways of really determining whether your numbers are right or you don't feel well with a disease that it just sort of creep in?
There you have to rely on change.
Over time.
Change over time. But let's not take just the early stage. Let me detail something which happens all too frequently. We have wonderful tests now, give us numbers. And one of the tests we use when a person has glaucoma is we ask them to see what they can see around them, and we can document that very carefully and give them a number of what they don't see here and what they don't see there and so forth. And then that's all printed out on a printout. Now, it's not at all rare, unfortunately, to see a person who says, my doctor tells me my visual field is staying the same. He does these fields, and the areas that are black where I don't see, he points out that, that's not enlarging. But I think I'm getting worse. I'm having more trouble in the dark. Things I used to be able to see, I can't see now. The key here is the tests often miss things.
Like your lived experience.
That's right. And very specifically, this very fancy visual field test, if it's black already, it just means it's being black to the particular object that you're being tested with. If it was a bigger object or a brighter object, you might be able to see it. But you don't give that bigger object or the brighter object because the test only has certain limits to what it does. So you're actually getting worse, and the test doesn't find that. So whenever you feel that you're getting worse and the tests seem to indicate that you're not getting worse, you better be pretty skeptical about that. Either you're getting worse emotionally, which certainly can happen, but that's getting worse, or the test isn't detecting what's actually happening in your body.
Well, let me ask you, if someone who's listening, and it doesn't matter what kind of test they are getting, it could be their eyes, it could be a cardiac test, it could be any kind of test. This is a really sort of generic discussion.
That's right.
Sort of it fits a lot of different situations. What do you think people should do? What's your advice to our listeners if they do get tests and they look normal, which on first glance it's almost like, whew, that's good, but they sort of know that they're not feeling as well or that things are getting worse? What's your advice of how they should handle that?
Nancy, we started out talking about my experience with glaucoma and how I got to be rather passionate about this. Most doctors became doctors because they really want to help people. They want to help people stay well, and they don't want sick people to get sicker.
Right.
So I think if you come from that point of view and then say to the doctor, you know, I know these tests seem to indicate that everything's all right and you're not finding anything right away, but I want you to know that I'm concerned. I'm worried that, you know, something's happening.
So you really are saying that people should be like really honest and open.
Oh, absolutely. Absolutely. Really honest and really open. And furthermore, pleasantly difficult.
All right, give us the formula for that. Your colleagues are going to love you for this one.
No, I mean that. Remember, they're in a difficult position. But if you don't seem to be heard, get yourself heard.
So you're saying, is the doctor's in a difficult position?
Sure.
All right, tell us what you mean by that.
There are 15 people waiting in their waiting room,
Right.
and they're already feeling terrible about those people that have been waiting there for so long, and you know, they don't want to take more time with you, who, as far as they can see, seems to be okay.
Right.
So you have to convince them that it's worth their time to listen to you well.
Right. We've talked in other shows about how to be your own self-advocate, or to take someone with you who can advocate with and for you. That could be a professional advocate in some cases, or it could be a family member. Because, you know, what Dr. Spaeth is saying is it is hard to really stand up for yourself when you know that everybody's under pressure. You know, on one hand, you're trying to sort through your own ideas and your own thoughts and feelings, and you're also picking up the sort of the conveyor belt that everybody's operating on in today's very fast-paced world. But I think to hear from you as a physician who has dealt with hundreds of thousands of people, it really is important to hear it from the horse's mouth, so to speak. And that you really, I think, are speaking for many, many people. That if the patient or the patient and a family member says, it just doesn't add up for me.
Right.
I really need to know, is this the right direction, or is this the right test, or why am I still feeling so poorly?
Just the other day I saw a person, and I thought everything was fine, and was saying goodbye to them. And then they said, and you know, also I have, and I said, no, say that again. And I also noted this, and I was so grateful, because then I went back and looked at something I hadn't looked at before, because I don't usually look at that. And they had something of real concern.
Right, something that would contribute to,
That's right, something
to their
that
problem.
was but I wouldn't have done that if they hadn't said, I don't think you really heard me as I was talking earlier, and you know, this is really, I'm so grateful when patients don't let me screw up.
Right, right. In preparing for this presentation, we did talk about how there are certain circumstances where numbers do matter. And there are some numbers that are always going to be bad news. And that's really, I think, what we're trying to help you differentiate as listeners. When do you sort of have some skepticism in terms of this total picture? And what are the circumstances where you should really listen up and take action because it is serious?
We mentioned earlier, you mentioned earlier that glaucoma is a condition in which frequently you don't have any awareness of being sick at the start. There are certain numbers with glaucoma that you better pay attention to. If you come to see me and you say, I'm feeling fine, but I think I need new glasses, and I check you out and I find your pressure is 60 millimeters of mercury, you can be asymptomatic. That is to say, you can have no awareness that anything's wrong.
Right.
But I can assure you, 100%, you're going to go blind. So when figures are in an area where they're always abnormal, not just slightly, statistically, but always abnormal, you better listen up and you better pay attention, even if you think you feel fine.
Right. So I think in the example that we have here, just using this as a point of discussion, with the numbers that you gave earlier with glaucoma in that range of interest, which was between, 15 and 23?
Something like that.
Okay, but if you're 30, 40, 50, 60, you're way off the map.
That's right.
So that's the point that I think George is making. You can't debate everything because some things are just simply not debatable. And I think that that's a good thing to realize. I mean, if your temperature is 106, you have a fever.
Yeah,
I mean, there's no debate about that. You know it, and so does everyone else. But if you have, if your temperature, some people have very varying, 98.6 is not necessarily normal for everyone. Some people have slightly lower all the time. Some people have slightly higher. So that is, sort of considered a very reasonable range. But I think that the take home from this program today is that Dr. Spaeth is telling us that in that relationship that you have with your physician and your treatment team, whoever is following you, is a very important relationship for you to have these open discussions and to be able to really bring all of the elements of your situation to bear on the treatment plan. You can't wait till the last minute when you're like walking out of the office, as his example was, to sort of bring something up. You rather want to do that at the beginning of the discussion, so that's all part of how the plan is going to go, because you're using the time most wisely, and your physician is also helping you to really make the right determinations. But I think at the end of the day, what I've really enjoyed is your candor, because it does take someone who is a thinker and someone who not only is highly educated and highly dedicated with a tremendous amount of experience, but who is also willing to throw out old ideas and old protocols and embrace new things. And I think that is a lesson for all of us in healthcare. The treatment team really has to be open to new ideas and to new research and to new findings. And we want you, as our listeners, to be open and receptive to these messages as well. This is not just a theoretical discussion. This is all about you. This is about you taking responsibility in a very good way, in a way that's going to make you feel so much more in control and so much happier about the care that you're going to get from people like George Spaeth and many others. So thank you so much, Dr. Spaeth, for being with us again. It's just been a profound pleasure to be with you. I mean, it's just fabulous to be with someone with this much knowledge and experience. And I most want to thank our viewers for being with us today for this very intelligent discussion, and something that I hope you have learned from this and something that you can take away for yourself. So thank you very much for joining us, and remember, with health, all things are possible. Have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.